Welcome back, everybody. David here with Med School Bootcamp again. So in this chapter, we are now going to start to talk about some of the most commonly tested renal pathologies that they ask about on board exams, and that is those that include nephrotic syndromes and nephritic syndromes. So first, we're going to start with a general overview of what these are, and then we're going to dive into each one individually. So in this first video, I want to revisit a little bit about the glomerular filtration barrier. Remember, a lot of substrates are filtered at our kidneys. We have a barrier that essentially allows certain things to pass through that we need to, ultimately get rid of in the urine, and other things are not typically allowed to pass through because we want to keep them in the body. We want to retain them. And so when we have disruption to the glomerular basement membrane, certain molecules, such as proteins in red blood cells, can actually filter out and be seen in the urine. This is indicative of a pathologic state. This is not what we would see in a normal, healthy kidney. The glomerular filtration barrier is composed of three key components, including the podocytes, the basement membrane, and the endothelium. So you can see on our diagram over here, we have the endothelial cells, which are on the most inside portion of the vascular system. These work to prevent large proteins from being filtered through at the glomerulus. Next, we have our basement membrane, which is kind of the intermediate or middle layer of the three components of the glomerular filtration barrier. And this barrier is kind of unique because it contains an overall negative charge due to something called heparan sulfate. Why is this important? Well, remember that negative charges are going to repel each other. Remember, with magnets, like repels like. And so a very important negatively charged molecule in the body is something called albumin. So typically we don't want albumin or protein in the urine. However, a disruption in this barrier can actually allow albumin to be in the urine, which we're about to talk much more about, as this is a key finding in these pathologic states, including nephrotic and even nephritic syndromes. And finally, we have our podocytes, which is kind of the outer layer of the filtration barrier. And these are specialized epithelial cells that cover the outer surface of the glomerular capillaries. So next, let's dive in and talk about nephrotic syndromes. Recall from an earlier video, I told you to think about protein when you think about nephrotic, the O in nephrotic, nephrotic, and protein. And here's why that is. So the general idea here is that in a nephrotic syndrome, we have damage to the filtration barrier, right? And we're allowing substances to pass into the urine, pass through the kidney that would not typically be allowed. The reason that we have damage to the kidneys is typically due to an increased level of cytokines. And recall that cytokines are any number of molecules that can include interferons, growth factors, interleukins, basically anything that stimulates the immune system or a localized reaction in the area can ultimately damage the filtration barrier. This can then lead to something we call podocyte effacement, which essentially is just saying flattening of the podocytes. Ultimately, they are losing their structural shape and they are losing their effectiveness in helping maintain the filtration barrier. This can then result in an ultimate loss of that negative charge. And we talked about that negative charge being established by something called heparan sulfate. And if we lose that negative charge, we then again lose portions of our filtration system in which negative charges are no longer repelling other negatively charged molecules and thus allowing an easier time for molecules to pass through the filtration barrier. So again, the overall principle here is that there is a reaction that damages their filtration barrier, and substances that we would typically not want passing through are now allowed to pass through. So what kind of problems does this cause in the body? Well, the first one we already mentioned is that we would then see albumin leak into the urine. So less albumin in the body. What do you think that's going to do to our body? What's a physical exam finding that we might see? Well, if you remember back to the videos where we talked about our oncotic pressure and our hydrostatic pressure, remember that proteins in the serum is a major pull of fluid. That's a high oncotic pressure. So if we're losing those molecules in the urine, what's going to happen in the serum? Well, let's take a look. If we initially had a bunch of protein molecules, that's going to want to pull fluid into the vascular system. However, let's say we have fewer molecules because we've lost some of them in the urine. What's going to happen? Well, overall, our oncotic pressure is going to decrease. And so now we're going to get much smaller of a pull into the vascular system, which means more fluid can actually hang out here in the extravascular space. And this is why we get edema. We're also saying that more protein is going to be in the urine, so it makes sense that we would get proteinuria. And additionally, we can get dyslipidemia. Now, this one doesn't necessarily make sense at first, but the thought process is that the liver can essentially sense the falling albumin levels and an overall low oncotic pressure, and it essentially acts to counterbalance this by increasing hepatic lipogenesis. So that is to say, in response to low albumin, we can get dyslipidemia because the liver increases production. So these are all things that can happen as a result of decreased albumin. Now, what about decreased antithrombin 3 or decreased immunoglobulins? Well, remember that antithrombin 3 is a molecule that helps control blood clotting. So if we lose this, it makes sense that we lose our ability to monitor this system, and thus we can have a hypercoagulable state. And again, the reason is that we have damaged the filtration barrier in the kidneys, and so molecules that are not typically allowed to filter through are now filtering through and being excreted from the body in the form of urine. It's the same thought process with immunoglobulins and thus an increased risk for infection. If we have a bunch of immunoglobulins that are then getting washed away in the urine because they've now been filtered through the body, we have less of them to protect us from an infection. And so again, the whole point here is that we damage our filtration system. We are now losing a variety of important molecules in the body. Some of the most commonly tested ones include albumin, antithrombin 3, and immunoglobulins. And so then you think about what are the adverse effects that can happen if we have less of those molecules. Well, if we have less albumin, we have less oncotic pressure and thus edema. If we have less antithrombin 3, we're hypercoagulable. And if we have less immunoglobulins, we're at higher risk of infection. So then again, the classic findings of a patient that is presenting with a potential nephrotic syndrome includes frothy urine. Why? Because we're getting rid of proteins in the urine, which can create a frothy appearance. You can also have edema. We talked about that in relation to the oncotic pressure and proteinuria. One of the key numbers they want you to know for this is that a nephrotic syndrome is typically consistent with greater than 3.5 grams in a 24-hour period. That is to say, if there are greater than 3.5 grams of protein or proteinuria in the urine over a 24-hour period, this patient has findings that are consistent with a nephrotic syndrome. Again, as with most numbers and cutoffs in medicine, these things are not exact, right? Just because a patient had 3.4 grams, that doesn't exclude them from nephrotic syndrome. It's a general range that we use. And for test taking purposes, 3.5 is most commonly used as the cutoff range. So then it might make sense to you if I said, what's the way to work up these patients? Well, a common way to do this is to measure the protein in their urine over a 24-hour period, which can be done. However, as you can imagine, this is not super practical, right, to gather a 24-hour sample of a patient. And so we have another way of doing this, which is called the spot urine protein to creatinine ratio. And if this is greater than 3.5 to 1, that is also indicative of nephrotic range proteinuria. So essentially, the urine protein to creatinine ratio is used as an estimate of what we would hope to see in a 24-hour urine sample. It's just much quicker to use, which is helpful for working up a patient. Typically, these diagnoses can be made in a clinical context where we gather some labs. However, the only definitive diagnosis really involves a renal biopsy to actually look at these things under a microscope. However, I will say for test-taking purposes, that is rarely the answer because it's very invasive, and typically a diagnosis can be made without doing such a workup. So next, we're going to move on to nephritic syndromes. And you will likely notice that there are a lot of similarities between nephrotic and nephritic syndromes, but it's the differences that I really want you to pay attention to and be mindful of. So if we look at our pathophysiology, it's kind of a similar process. You get some sort of inflammatory reaction that's occurring. This ultimately damages the filtration barrier and the glomerular basement membrane, and this can lead to a lot of similar findings as a nephrotic syndrome, but one of the main differences is that you'll see dysmorphic red blood cells. And more specifically, seeing red blood cells in the urine is something that presents as more of a nephritic type of syndrome compared to a nephrotic type of syndrome is more based around the protein requirements that you need to make the diagnosis. So you can see here, I've said there are a lot of similar findings to a nephrotic syndrome. Overall, there's typically less proteinuria. So sometimes the classic cutoff is 3.5, we said, in a 24-hour period. So if it's greater than that, it's a nephrotic syndrome. If it's less than that, it's a nephritic syndrome. Of course, this is a bit of an oversimplification for actually making these diagnoses in practice, but for understanding the basics and the fundamentals and doing well on test questions, this is a good way to think about it. So anytime I'm presented with one of these questions, if I'm only seeing symptoms related to protein loss, I'm thinking about nephrotic. But if I'm seeing something about protein loss and red blood cell presentation in the urine, then I'm thinking about a nephritic syndrome. So in nephritic syndrome, we're seeing an inflammation of the glomeruli that can basically damage our filtration mechanisms. And because of this, we would expect to see a decrease in our GFR and an increase in our creatinine, overall due to inflammation. Well, remember, what happens if we decrease our GFR? Our body can respond by ultimately activating the renin-angiotensin-aldosterone system. And do you remember what's the goal of the renin-angiotensin-aldosterone system? That's right, it's to retain sodium and ultimately more fluid, because the kidneys are sensing a low volume status, even though that might not be truly indicative of what the body is experiencing. And because the kidney senses low volume status, it responds by activating the RAS system. This ultimately leads to more reabsorption of sodium in water, and thus some of the classic findings of a patient with nephritic syndrome will include things like hypertension and edema. We would also see things like red blood cell cast, hematuria, and acanthocytes, which, as a reminder from a previous video, is a type of dysmorphic red blood cell. And the reason is because in these nephritic syndromes, we primarily are having inflammation at the glomerular basement membrane itself. This damage to the glomerular basement membrane is what really creates these kind of dysmorphic red blood cells that are classic for nephritic syndromes. And finally, we said kind of one of the differentiating factors is that, yes, there's still proteinuria, but it's overall less than we would expect to see in a nephrotic syndrome. Again, these are ranges used for test taking purposes. In clinical practice, they might vary a bit. So to simplify things, we say if it's less than 3.5, it's more likely to be a nephritic syndrome. And if it's greater than 3.5 grams per 24 hours, it's more likely to be a nephrotic syndrome. And finally, the workup for this condition involves very similar things, such as a urinalysis, which is always going to be the best test. We want to do least invasive, fastest thing, versus a renal biopsy. It's obviously going to be more invasive and potentially take quite a bit longer. So there you have it. There's kind of a general overview of our nephrotic versus our nephritic syndrome. Some of the major takeaways here are what damage is actually occurring. For the most part, we think about nephrotic syndromes encompassing damage to our podocytes, leading to a massive protein loss. Nephritic syndromes are more so looking at glomerular basement membrane, leading to our dysmorphic red blood cells. And so those are kind of key differentiating factors between the two pathologies. However, there is a ton of overlap, right? In a nephritic syndrome, we still see some protein in the urine. We still could see some antithrombin 3 deficiency, and we can still see loss of immunoglobulins. So there's a lot of similarities, but a few key differences to really hang on to as we progress forward. In the upcoming videos, we're going to break down each of the important nephrotic syndromes, and then eventually the important nephritic syndromes for you all to get your questions right on test day.